room right now. So everybody's just coming in and settling down. But let me go ahead, Mason, and introduce you, and you'll be able to share your slides from there. Mason, just since you don't know as much about UNC, Eshelman School of Pharmacy, we about 3 years ago, we started this Bizzell Business of Healthcare lecture series where we bring individuals that historically have been called non-traditional, but I think it's becoming much more traditional than in the past. Oh, here we go. Now you can see the audience. And the bringing individuals in to expose them to different career opportunities, networking, building out individuals that they can connect with and help them see all the opportunities one can do with a pharmacy degree, which are much more than just hospital and community. And so that was sort of the intent of this. And we're really excited because Mason brings in a very different perspective than what we've heard in the past. He got his Doctor of Pharmacy at University of Washington, did a PGY1 and PGY2, very traditional sort of steps after you get your pharmacy degree, but then joined the BMS or Bristol Myers Squibb's Foundation, where he's currently the senior program manager. And one interesting thing, and I liked how he wrote on his LinkedIn page that he's working in the social impact sector focused on advancing health equity, which again, all based upon very traditional educational perspectives. And so Mason, I'll turn it over to you. Thank you for joining us and look forward to hearing a little bit about sort of what the sort of the BMS Foundation roles and activities are for future pharmacists.
Thanks for the introduction, Dr. Eckel. So really glad that you all have the opportunity to have this sort of class. I remember doing something similar at the University of Washington, but it was still pretty limited. It was still like compounding pharmacy, for example, not quite to the industry world. And so really excited to be able to introduce you to corporate philanthropy and public health alternatives for pharmacists. So as Dr. Eckel said, my name is Mason Chiang. I work as a Bristol Myers Squibb Foundation senior program manager, and I've been in role for about 2 years now. So I'm gonna just pull us through a little bit of my career path and then a little bit about my PGY2, and then talk about the foundation, the programs I help direct, as well as a short kind of one slide about opportunities within industry for public health. And feel free to stop me at any time if anybody has questions, if either through the chat or just raise your hand. I can't see super well, but I will do my best. So to just start off with my career journey, similar to many of you, I went through a very traditional kind of clinical pharmacy route. So I started off at the VA in Ann Arbor in Michigan as a pharmacy volunteer. And then through that volunteerism, I did get the opportunity to work as a technician for about 2 years. And then when I went to the University of Washington to start my PharmD, I got the inpatient pharmacy internship there and worked there for about 3 years. And in that position, worked throughout all our pharmacy units, including our main pharmacy, but also our oncology and our ICU satellites and our NICU satellite. I took some time off during my training, and I'll go through that. And then, so I did my APPs a little bit in a delayed fashion, which kind of pushed through my postgraduate training as well. So I actually did pharmacy school in 5 years instead of 4 because of some non-traditional experiences, which I'm going to go into. So the first thing that I did within pharmacy school, I was actually a little bit displeased with what we had offerings in terms of our extracurriculars. At that time, we didn't really have dual degree programs at the University of Washington. I think that's changed now, but I really wanted to learn more about public health and global health. And so I did a graduate certificate with the School of Public Health, specifically in global health. And through that, I needed to do a capstone project. So as part of my capstone project, I got this Thomas Francis Jr. Global Health Fellowship, and I participated in a 4-week program, which I basically designed by myself, and I worked in Cambodia with a private public hospital to do health system strengthening. And this was my first foray into what pharmacists can do outside of a more traditional like pharmacy practice setting. That was a really stressful time for me. I'm not gonna lie. I didn't know what I was doing. I just finished my first course in therapeutics. And so I was still struggling to figure out what was heads and tails. And if I were to do that again, it'd be a very different experience in terms of what I would be able to bring to the table. But thankfully, because I had my pharmacy internship experience, as well as some therapeutics knowledge under my belt, I was able to impart some knowledge there and understand really what the program was doing, the pharmacy program was set up to do in Cambodia, and how we could help advance that work. Since then, I've actually had some of the pharmacists from that program reach out to me after the fact, after I was there, to kind of ask for some resources and help. And so really happy to be able to have done something like that to help strengthen their pharmacy health systems. In addition, I took a year off to do a Bonderman Fellowship. So Bonderman Fellowship's a little bit different. I always like to mention it because it's a non-traditional experience that I really feel like has impacted my overall trajectory. So in this specific travel fellowship, I actually didn't do any work or research. It was really travel for the sake of travel. And so I spent about 8 months in South America and in South Asia, Peru, Bolivia, Argentina, Chile in South America, and then Nepal, India, Sri Lanka. And so this was really just for me to travel, enjoy my life, and take a step back from the world of pharmacy. The way that I had phrased it was, when you work in pharmacy, sometimes you kind of lose sight of the patient a little bit. It's case-based, it's working behind your EMR, it's working behind Epic, whatever it is. So for me, I felt like I was losing why I wanted to get into pharmacy in the first place. And so wanted some time to myself to reset and to really understand why I wanted to get into healthcare in the first place and rediscover those passions. And so this was a time for me to connect with myself, but also connect with a global peoples. Did my APPs and then came back and did a PGY1. So I did mine at Sutter Health, which is California Pacific Medical Center. It's a tertiary care center in San Francisco, highly acute care focused. I didn't do any outpatient experiences. I did 6 out of my 8 rotations were ICU focused in some way, shape, or form. So highly intensive acute care program. And then after that, I did a PGY2. So this PGY2 is not a traditional PGY2. It's not ASHP accredited. It's a program specifically through the Rutgers Pharmaceutical Industry and Fellowship Program, RPIF, and the BMS Foundation. So this was kind of how I got into my current role, was through this program. And so I'm just gonna go over the program itself. Give me one moment. I'm gonna talk about what the foundation is and who we are. So at the BMS Foundation, we envision a world where everyone has access to quality healthcare, regardless of who they are or where they live. Together with our partners, we strive to bridge the divides that prevent people from achieving optimal health. And so what optimal health looks like to us is a health equity state where individuals and communities around the globe have fair and just opportunities to attain the highest level of overall health. We've been working in health equity for underserved communities for nearly a quarter of a century. Before, health equity was this huge buzzword term that you hear nowadays. And we've been really working in it for 25 years, from the African continent to China and across the Americas. So the program that I did with the BMS Foundation, the Public Health PGY2 program, was created in 2009. And this program really is a place where we can give residents the opportunity to have a variety of global and domestic experiences in resource-constrained settings. I think traditionally we often think of the global setting as like low and middle income countries as having resource constraints, but really within even domestically within the US, there are many communities, rural, indigenous, whatnot, that have resource constraints that we need to also recognize and understand. So to do public health work, you don't necessarily need to go abroad. There's lots of public health opportunities here within the States to also engage in and learn those concepts. So the way that this program is set up is you spend half of the year, 6 months, in Southern Africa, and we work directly with the BMS Foundation team in Africa and the Global Cancer Disparities team, and we help build capacity and provide training to partner organizations. And so the residents is sent to Africa for 6 months and works directly with hospitals, clinics, community-based organizations, and we work to develop some of that work. So I'm going to give you a snapshot of what I did. I actually only spent 1 month in for my experience because of COVID. There was, I think, just as I was entering and wanting to plan my 6 months, there was a spike in Delta. And so we actually had to cut that down to 1 month, but still was able to do a lot of really interesting work. So I spent a total of 4 weeks there, and I worked with 3 grantee partners across 2 countries, South Africa and Lesotho. In Lesotho, I worked with the first in-country clinical oncologist to stand up the country's only outpatient in clinic and infusion center. This was a really big deal. The residents of Lesotho would otherwise have to actually travel across borders into South Africa, which is truly, it's not super long of a journey, it's about 3 hours, but really people coming from further out in the countryside, it might take an entire day to get even to the capital city and then get into Bloemfontein where some of the clinical oncology work was being done. And so it takes a lot from a patient to afford that and be able to take the time out to get cancer treatment. So getting in-country clinical oncology was a huge, huge deal and a step forward. And the foundation was funding some of that work and that training. In addition to the work I did specifically with the clinic, I also presented several lectures as a guest lecturer at the National University of Lesotho School of Pharmacy, as well as with our clinic staff directly. And through our program, I identified 15 needs through a comprehensive needs assessment and resulting in over 30 unique actions and resources that I helped pull together. In addition to working with the university, with the Lesotho Oncology Clinic, I also worked with the University of Free State and Bloemfontein, spent some time there understanding how their palliative care unit works, as well as how their oncology unit was working. So to give you a little bit of a sense of what that clinic in Lesotho looks like, it's a one-story clinic. They have a clean room, which I was really impressed to see. They didn't have necessarily the secondary controls that were needed to make this a traditional clean room as you and I might be more familiar with, but they did have at least a primary engineering control, which is great to see that they had a chemotherapy hood in place. And this was originally, the center was actually funded by BMS through Secure the Future, which is an initiative specifically focused on HIV and AIDS, as well as tuberculosis, but then has now shifted to grow and expand into cancer care as well. So some of the major outputs that I created through this program was to co-develop some standardized chemotherapy administration guidelines. Thankfully, through my PGI 1, I had a good number of oncology experiences, including verification and kind of the drug-based information kind of research that I needed to do. So I had the right resources to do this work. And so we often have someone who's PGI 1 trained to actually do this program because of that. As well as, in addition to that, I also helped do some hazardous drug admixture needs assessment. I worked with our team on palliative care treatment guidelines and commented on some of the clinical things that I would see or I would utilize, and then participate in some of the clinical rounds as well. And so this is just an example of the chemotherapy administration guidelines. So I would go through all of their different drugs that they were wanting to use, give some pre-medication guidelines, administration instructions, precautions, things like that, that you all might be very familiar with as you work through pharmacy school. And so just to give you a quick lessons learned slide, global health and health equity work is rooted in strong partnerships. For me, it's all about the partnership. So it's really about finding the right people to work with and having authentic and sustainable relationships with those partners. I'm not a fan of that sweep in, parachute in, and say exactly tell the community what they need. The community knows what they need. And so what we want to do is be able to enable them and to help give them progress to their own goals and needs. And so creating these sustainable relationships that are long-term and are really authentic, where you get to know the people outside of just the health work that they're doing, really as people who they are, is really, really important to be able to drive change and move the needle in this aspect. The other thing that I think I learned was really that your value doesn't exclusively lie within your professional or technical skills as a pharmacist, right? So I came in thinking like all they're going to want to know is all the pharmacy knowledge I have. But I recognize just that being there in it itself was a presence for change. I remember at one point, like someone was telling me, the reason we're holding this meeting is because you're here. So you're really catalyzing the change for us to even have these conversations. I really tried to take my learnings and be really proactive. So I did a lot of administrative support, taking notes during meetings, reaching out and creating contacts and relationships via email after the fact, and just giving a new perspective on some of the things that we all do in the US and trying to build it back into what they're doing in Africa. And so really just wanted to remind you, I think when I was going through this work, and I still do have a lot of imposter syndrome of like, who am I to say what you all should be doing? Like at that time, like a 27-year-old kid who really just didn't know very much. But I think as just being there really is a catalyst for change. And so to really not sell yourself short in this work. And so I like to really think about maintaining strong communications with the partners that you're working with, setting realistic expectations. I was there for a month. I'm not going to change everything that they're doing within a month. But I also recognize that I had someone coming in a few months that'd be there for longer. And so the next resident would be there in July. And so I could help set up the systems that they need to eventually make change. I think the other thing is to really lean on your network, know what you know, but then know what your limits are and know who to ask, right? So I think that's the biggest thing about pharmacy is like, you don't know every single drug information piece of knowledge out there, but you do know where to look for it. And so it's the same thing about you might not be an oncology expert or you might not be a public health expert, but who do you know within your support system, within your orbit that might be, right? And who can you contact and reach out to? Thankfully, because I worked in something similar like this during pharmacy school, there are folks that I worked with there that I could reach out to, as well as my PGY1, and as well as as well as the BMS Foundation to ask and be like, hey, I don't think I'm the most appropriate person to know this, but who do you think would be a good starting point, right? And then the last thing I always like to remind people is learning is always bidirectional. So you will be learning as much as the folks that you're working with are learning from you. And so taking a moment to stop and check in with yourself. What's going on and how are you going to bring that forward into the work that you do in the future? And so just to give you, I think pictures are really nice. And so I like to just give a quick presentation on pictures as well. So these are some of the folks that I got to work with throughout Africa, specifically in South Africa and Lesotho. This is some of the great food that I had while I was there. Lots of delicious food that I was able to taste. And then lastly, I did do a safari. So I saw lots of really cool animals. It was my birthday weekend, one of those weekends. So I decided to go out to the national park out there and Kruger National Park and do some sightseeing. And then got to experience some of South Africa and its beauty and glory. I had my director at the time, her son was getting married. And so I was really lucky to be able to participate and join in at a traditional wedding, as well as just exploring South Africa and some of the sites that they had. Some more pictures. Cool. So that's my PGY2 summed up really quickly, and then I'm going to just shift focus into what I do currently. So the Bristol Myers Squibb Foundation is a global foundation, so we advance health equity across the entire globe, and we have certain markets that we work in. So obviously we work in the US. All the orange boxes are the places that are, or the portfolios that I currently help manage. So in the US, I help manage the global cancer disparities focused on lung cancer, as well as the Robert A. Wins Everseen Clinical Trials Award Program. And I'll talk about both those programs. In addition to the US, we also fund in Africa, Brazil, and China. In Africa, we have 10 countries within our portfolios, including South Africa, Lesotho, Ethiopia, Tanzania, Kenya, Eswatini, Zimbabwe, Botswana, Malawi, and Uganda. And then I also help run the Global Cancer Disparities Program in China, focused on lung cancer and gastric cancers. I think I skipped a slide. Okay. To give you a sense of the scope of our foundation and the work that we do, In this past year, we were able to reach 363,000 people in the targeted communities that we were trying to outreach to, which includes anything that's underserved. Underserved for us is defined as doesn't just cover racial and ethnic minorities. It also covers LGBTQI status, socioeconomic status, insurance, veteran status, lots of different things that might cause someone to have a low health equity or something that's not an equitable access to healthcare. We had over $200 million committed to our current grantee projects, with 86 active projects within 11 countries and 4 continents across our 6 portfolios. So speaking directly about our Global Cancer Disparities Program here in the US, we've been working in this since 2014 when lung cancer screening was first published in the end of 2013. Our foundation was one of the first companies to really get into working in lung cancer. Lung cancer continues to be one of the highest mortality cancers throughout the world, not only the US, but the entire world. And so you'll see lung cancer kind of pulled through in all our portfolios. Specifically in the US, there's lots of disparities for Black Americans, Latino Americans, AIAN, as well as veterans. And so I'm not gonna go through all of them here, but we do have kind of the why stated on our slides. Currently, we have about 17 grants. 3 of those are nationwide programs that are either telehealth or education programs. But we do have where our current impacts mapped out here. And the opportunity that we're looking to fund is to improve screening, early diagnosis, and treatment through these community-based models of care. We know that if we are able to catch lung cancer early, that we're able to then be able to treat better and have better outcomes in the long term. In 2023 specifically, we have a special focus on indigenous populations, and I'm actually in the process of reviewing the applications that we received for that. I'm looking forward to be able to fund some work that will specifically focus on indigenous populations and lung cancer. To give you a sense, I feel like I've talked a little bit about what my work is, but it's kind of hard to really see exactly what that work is until you have some examples. So I'm going to give you 4 examples of some of the early grants that we had from the 2014 to 2021 range and try to figure out, just give you an example of what we fund. So with Levine Cancer Institute, we screened over 2,000 rural lung cancer patients through the development of the first mobile lung screening mobile unit in the US. We call this the lung bus, and basically what we did is we put a CT scanner on a mobile bus that drove that out to patients. So bringing lung cancer screening directly to patients instead of having them come to the clinic, go through all the transportation and other sorts of barriers, time off, things like that might be needed to get lung cancer screening, and took it directly to the patients. This program was so successful that Levine Cancer Center actually then invested a second lung bus, and then since then, this model of care has been used a lot throughout the US. I've seen several programs come through and ask for more funding in this space, as well as programs internationally within China and Brazil have also shown interest in doing some of this work. Since then, also commercial products, so a large vendor has created a lung bus that you can buy and just have sent out to folks. So it's really been a really great way of seeing screening rates improve in underserved groups. The next program, the VA, we created the National Tele-Oncology Program, and this program is really connecting rural cancer patients to the high quality care you might find at an academic center in a larger city. And so this would be able to, since I think veterans are 1.5 times more likely to live in a rural area. This program really allows them to have access to the highest quality care through a tele-oncology program. Now, when we funded this in 2019, this was a really novel concept of using telehealth as a way of connecting patients. now that we're post-pandemic, I don't know if post-pandemic, now that we've gone through the brunt of the COVID epidemic, we've now seen that telehealth is a really powerful resource that is now seems commonplace. But at the time of funding in 2019, this was a really innovative way of connecting patients. And we've had a lot of really amazing success with this program. The tele-oncology program has actually been catalyzed to do more because of the pandemic. And so in the 4 years that we've been funding them, over 7,000 veterans have been seen through this program with over 26,000 encounters, which is really huge. So the second to last program, the VA PALS program, this is a screening program that we set up through the VA that stood up 10 screening centers throughout the country and screened over 13,000 veterans and detected over 300 cases. The reason that this was so impactful outside of just the numbers is that it was really a program that kept lung cancer screening on the radar for the VA outside of at the time when they really didn't have any impetus. After this program was completed, the Congressional Budget Office had actually allocated $70 million to continue doing lung cancer screening work through the LPOP program. And so our program really did kind of keep the screening lung cancer on the radar for the VA. And then lastly, I want to talk the Kentucky LEADS program. This was a three-pronged approach to lung cancer education and outreach. And the program itself was really focused on redefining the screening landscape in Kentucky. The project actually lifted Kentucky from 49th in second worst in the country to the second best in the country and reduced the late stage cancer diagnosis by over 10%. And so really having sustainable change and deep change within communities that were really highly affected by lung cancer. There we go. And then Global Cancer Disparities Initiative in China was a portfolio we recently took over in the last year. And so still working through that strategy. So our program goal is to align with the Healthy China 2030 program and to work to focus on lung cancer and gastric cancer. We're going to be looking at two things, basically, to reduce rural disparities and to strengthen healthcare workforces through nursing models of care. Because this program is still slightly new and just came into my kind of remit in the last year, it's still something we're developing, but we're really looking forward to working with Chinese organizations to further lung cancer and gastric cancer screening. So once again, this is another kind of broad overview of the foundation and the different impacts that we have. And I'm not going to go into it too much because will take quite a long time, but just gives you a good sense that we do work globally across the world with lots of different organizations and committing lots of different grants and grant amounts to different organizations to do different work. The last program in my remit is the Robert A. Wynn Diversity in Clinical Trials Award Program. This is slightly different than our other grant-making programs. So this program came as part of the 2020 response to health equity issues. And so this is part of our health equity commitments. We are aiming to transform the clinical research landscape and to really train a new generation of clinical trialists that are community-oriented. We recognize that although clinical trials are small, they're usually like 300 to 1,000 to 2,000 kind of patients, but we recognize that most of these clinical trials do not represent the patients that actually exist in our world. They're not a reflection of our public health. And so our goal is to really increase the number of clinical trialists, so people who are running these programs that have these community-oriented understanding in programs. So these new clinical trialists have community engagement and research skills through the Community Career Development Award, and we're working to train 308 of these new clinical trialists through 5 years of programming. And then we also have a program for medical students as well as some ongoing programs. So let me go through those. So our program is divided into 4. So the first one is our Career Development Award. It's a 2-year program for early stage investigator physicians. Our second two programs are only eligible for people who've completed our CDA. So it's one with Conquer Cancer and one with AHA. So each of these programs are really putting our CDA, our graduates, into positions of power within the clinical trial landscape. So for the CLA program with Conquer Cancer, that one specifically is working with the NIH cooperative groups. And then in AHA, they're working directly with the AHA subcommittees, who are huge funders in the CV space. And then lastly, our clinical investigator pathway program is a 6-week externship for our underrepresented medical students. These are just a quick slide of our different funding partners that work to support our program. And then if any of you are interested in learning more about the foundation or the clinical trials award program, feel free to either Google it directly or use these QR codes to scan to go to our websites. And then, so that's a quick kind of 30-minute introduction about the work that I currently do at the foundation. I want to spend the next like 10 to 15 minutes just talking about what pharmaceutical industry positions might exist within social impact and public health. As a pharmacy student, I didn't know any of this existed. I really wanted to do something in the public health space, and I really focused on like health system strengthening, working in kind of global health work. And this was kind of when I did my PGY1 is when or my PGY2 is when I really learned more about this. So the first part I'm going to use like directly the role that I work in now, which is corporate foundations and philanthropy. And so the way that I think about BMS Foundation is we are a nonprofit. We're a 501c3 separate and independent or a charitable organization that's separate from the company, but we are funded by the company. So most of these large pharma organizations actually have a foundation. You might just not know of it. So for example, Pfizer has a foundation, Novartis does, Genentech, all of them really do have these foundations. They serve as a way for these companies to get tax breaks, but they also are, it's real money that we're getting, right? We have over $200 million of grants that are committed through our programming. And so this real money, basically these foundations take them and they work independently from the company to dole them out for different kinds of grants and initiatives. And so that's the role that I currently hold, but we also have something called the Patient Assistance Foundation, and within the company itself, we do corporate giving. This is specific for the setup that we have at BMS, and so every company is going to be slightly different in how they set it up and how exactly they work through it. But I think this is a great opportunity for you all to be exposed to learning that these entities even exist, because I truly didn't know these kinds of things existed within pharmaceutical industry when I was a student. Within industry, I think there's other ways of also getting involved in social impact and public health. And so the three other things that I kind of pull out here is corporate social responsibility, CSR, ESG reporting, and health equity and clinical trial diversity. So corporate social responsibility, the way that I think about it is that as global citizens, these companies are, these multi-billion, million-dollar companies have a social responsibility to give back and to do good for the communities that they're working in and the societies that they're operating in. And so CSR is something that's really picking up within all companies, not only in the health world, but it's really how do we impact and give back to the society that we're working in. To do that, and this goes hand in hand, is how we report out, is called environmental, social, and governance reporting. And so this is something that investors actually now look at. They try to understand how these companies are engaging in CSR and how they're reporting out about it. And it does actually affect revenue and key stakeholder involvement, things like that. So ESG reporting is a huge space to also kind of learn a little bit more about. As I'm developing my own career, I want to learn more about how ESG is done and how ways that I can get more involved in that, because I think that's a really great way of translating the skills that you have into other industries outside of just pharma, but also really recognizing that that is what social impact work is. Lastly, I want to talk about health equity and clinical trial diversity. I'm going to speak about the second one first, it's easier. Clinical trial diversity is something that has changed from a nice to have to a business imperative. So the FDA in 2022 came out with a statement basically about, or guidance document on how clinical trial diversity would be evaluated going forward in our clinical trials. And so to get approval, you do have to now have a more diverse clinical trial that reflects the US population. And so while this was a nice to have in the past, this is now a business imperative for pharmaceutical industry. Companies, they have their drugs approved. And so clinical trial diversity teams exist at every single pharmaceutical industry company that you can think of. And they're working in different ways to increase their trial diversity. So it's working directly with communities, working with different institutions. So looking at minority serving institutions or historically Black colleges and universities as potential avenues to recruiting patients, working more directly with smaller clinics instead of just going to the large academic medical centers. There's lots of different things that are involved in clinical trial diversity that people are implementing within these systems. Health equity has also been a huge buzzword that's come about since around 2020, but has existed for a lot longer than that. When we think about health equity, we think about social drivers of health. I'm trying to unlearn the word social determinants of health, because determinants is very finalized. It's once you have this social determinant, doesn't mean that you can't have good health. So I like the word social drivers a little bit more. I think it's a better representation of the concept that we're trying to put forward. So thinking about how social drivers of health are affecting communities and how those might affect patients in terms of how they would get access to drugs, as well as be able to engage in healthcare. Obviously, that's a lot of the work that I do within the foundation, but the company is also really committed to thinking and learning more about that. At BMS specifically, we now have a health equity lead who does a lot of this work. So the company is starting to invest in health equity in a more systemic way, instead of kind of doing piecemeal things. And that's just what I see here at BMS. I know that a very similar thing exists at a lot of the other pharmaceutical industry companies, as well as things like payer systems. So thinking about insurances and different companies that might be paying into this healthcare system. Health equity is also huge on their radars. I've seen chief health equity officers and teams throughout all of those companies as well. And so I think there's a lot of opportunity for health equity to exist. So a big question I often get here is, how did you break into this space? I was quite lucky. My PGY2 specifically was working in this space, and PGY2 generally doesn't actually hire. In the 12 years that we've had this program, we've only hired 2 people directly into the foundation, me being the second one. And so really just the stars aligned. That being said, I think a huge way to break in is to really just show that you have interest in this work, right? So it doesn't have to be direct health equity work, but like, what can you do within your current role as a pharmacy student to show that you're interested in this and to learn more about it, to get your hands dirty and to just get more involved. So one great thing that I remember existed that I really didn't do much of was SNAFA, and that's a great organization to work directly with underserved communities. If you're interested in global health work, are there ways that you can support global health initiatives, either indirectly via like telehealth resources here in the States, or directly and going into doing mission trips or things like that. I think when we do mission trips, we just have to be really cognizant about our time spent and the language we use around that. So just that's another aside. But within the U.S., are there opportunities to work with the USPSTF, for example, or it's not PSTF, the Public Health Task Force? Are there opportunities to work with IHS, Indian Health Service? Are there opportunities to work with public health departments within your state? I'm sure North Carolina has a Department of Public Health that would love to have some pharmacy students come through on a rotation. And so thinking about underserved communities, you can also work with, I know at the University of Washington, we had a migrant clinic that we worked with. And so there's lots of different opportunities to work with underserved populations. How do we actually get our hands dirty and get some of that experience while we're in pharmacy school, and then bring that forward into our learnings and teachings in other aspects. Really, to break into this field is all about networking, who you know, and getting to and just reaching out to folks, right? So I am always a fan of people coming to reach out to me afterwards and being like, hey, interested in the work that you did. Glad that you kind of described some of the overarching aspects of your program. Can you answer a few questions and just get to know me a little bit more? Like, I think those are really appropriate things whenever you see that. And something you're interested in, you should definitely take the initiative to reach out to folks, and just to continue to follow up with and build your network within these spaces. I also really recommend experiential rotational programs. For example, our foundation does do a internship program, which would be a great opportunity for these students to learn directly and work directly with myself as well as our team to learn exactly what we do on a day-to-day basis. I actually think our internship program is maybe still open. I don't know for a fact. I review the applications, but I don't do the timeline stuff. And then the other thing to think about is advanced degrees. So I know UNC is really well known for having dual degree programs, including a master's in public health, I believe, and so as well as MBA. And so these are opportunities for you to build your skills inside the classroom to really understand exactly what public health foundational knowledge you might need to have, what business administration knowledge you might need to have, but also give you an opportunity to do some practical work to get a master's. It's my understanding that you also need to do some sort of more formalized, not dissertation, but something along those lines. And so thinking about other kinds of MSs and PhDs, I know there's an MS in implementation scientist, which would be a really great help for someone who's wanting to break into the public health sphere as well. So those are some of the things. I have specific ideas about all of those advanced degrees and their applicability, and it's not going to go into it because I think it's specific for the person and different, but I'm happy to talk about it one-on-one if some people have some specific questions. And lastly, for experiential rotational programs, I do want to point out that I did apply for the FDA and the CDC as for part of my APPEs. The other program I kind of mentioned earlier was the US Public Health. I can't remember the exact acronym for it. It's been a second, but they had the senior and junior co-step programs, COSTP. I'm sure if you look those up, you can find out what those public health programs look like. And that's directly what you work as a public health officer through the US government. They do emergency preparedness response. They work directly with like Bureau of Prisons as well as like the Indian Health Service, lots of things like that. And so really something interesting that I applied for, I didn't get, but a program that I always like to bring up here because I think it's a direct way of working in public health settings as well as with the government, which is always a nice job to be in, except when there's a government shutdown, I guess. Yeah, so that's me in a very quick 45-minute nutshell. I have my LinkedIn and a QR code here. If anyone wants to connect with me, feel free to, or reach out to me, feel free to. And I'm happy to take some questions in the next 15 minutes or let you all enjoy your lunch and let you out a little early as well.
Thank you very much, Mason. Very much appreciated an overview to both your own personal professional background as well as the BMS Foundation. Any questions from the audience?
Hi, can you hear me?
Yes.
Okay, thank you for your presentation. So something I'm kind of curious about, I know you did a residency, but I was wondering what are the pros and cons between doing a residency versus doing a fellowship if you're interested in this area?
Yeah, it's a really great question. So lots of fellowships exist. UNC is actually really well known for having some public health related fellowships that I tried applying for, but just timing wise hadn't worked out. So definitely look into those because you're already at the organization and the institution. The reason I ended up doing the PGY-1A is because I felt slightly forced to. Not forced to is not the right word. You have a lot of people telling you that a residency is important, I personally actually really like doing a residency. I thought it really built my clinical skills. You can do a lot as an intern, you can do a lot as a pharmacy student, but it's just not to the same scope. You don't have that same level of autonomy and independence that you might have as a resident or a practicing clinician. And so the way that I see it is you can always do more with the PGY1. With a fellowship, you're kind of trapped within the industry realm. Like you can't really go from fellowship back into a clinical role, whereas you can always go from a clinical role into an industry role. So I think for me, residency just opens a lot more doors and keeps things your options a little bit wider, and it builds your clinical expertise that you're able to speak more directly to the work. And so in my current role, I don't necessarily do a ton within clinical pharmacy work anymore. I don't use a lot of that clinical pharmacy knowledge, but I do use a lot of that healthcare experience knowledge. So I think a lot about how our healthcare system works and what I saw as a pharmacist that I don't think I'd be able to do as well if I hadn't done residency. It all really depends on what your end goal is. If you really do feel like industry is where you eventually want to end up in, I do think going directly through the fellowship route is probably the best way. If you're not sure, I feel like going through a residency is actually a great way of kind of expanding your options. There are many folks who, not many folks, there are folks who do residencies and then apply more generally to fellowships. To do that, I will say you probably should have at least one APP that has an industry focus, just so you can speak to it. Because a lot of folks, that's what they look in for in fellowship interviews. So that's just my one piece of advice. When it comes to public health, there's not as much public health fellowships that I know that exist. So this residency is one. UNC has a couple, and then Purdue has a global health fellowship program as well. I think those are the big ones. So there's not a whole ton of those, and so recognizing timing wise, Purdue only hires every other year. So if you're off cycle, you might not be able to get it. So things like that, you just have to kind of plan and think through a little bit early. Any other questions that I can help take?
It doesn't look like, let me just give everybody an opportunity. Well, again, Mason, thank you very much for your time and very much appreciate your willingness to come and speak based upon your experience.
Absolutely. Thanks for your time, everyone.